So the value-based insurance design movement has tremendous momentum in a lot of areas, but there's three specific ones that I think are worth noting. First is our 8-year advocacy to allow value-based insurance design principles in the Medicare Advantage space. And we were absolutely thrilled to see CMS, through the Innovation Center at CMMI, announce a value-based insurance design demonstration test in 7 states in 7 conditions in Medicare Advantage plans to change the non-discrimination aspect of Medicare, and that everyone has to have the same benefit design, was an extraordinary challenge, even though people understood that the delivery of precision medicine should have precision benefit design. It required a multi-stakeholder, bipartisan effort to convince CMS and the US Congress to back this idea. And we are absolutely over the moon with the fact that on January 1, 2017, a large number of health plans in 7 states will make this happen. So another key initiative in the VBID space is in the commercial sector, which is try to implement value-based insurance design principles in the fastest growing type of health plan in the US, which are health savings account high deductible health plans. It turns out an unintended consequence of the initial guidance for these types of plans did not allow any services besides some highly selected primary preventive services like screenings and shots and counseling to be covered in these plans before the deductible is met. So just about all of the high value services that we've been emphasizing in value-based insurance design in common chronic diseases are not covered at all in HSA HDHPs until people meet sometimes a $5,000 individual deductible and sometimes a family deductible of over $10,000. So we have put together this wonderful, strange bedfellow coalition of manufacturers, consumer advocates, policymakers, hospitals, health sciences companies to actually work very closely with the US Congress and the Internal Revenue Service within the Department of Treasury to expand the definition of what services might be included in a pre-deductible safe harbor, such as drugs for chronic diseases, HIV, depression, diabetes, or diagnostic tests like cholesterols or blood counts, or certain services like a diabetic eye exam or physical therapy after hip replacement. So we are very pleased that it is our real hope and expectation that as we were able to influence the Obama administration to allow VBID in Medicare, that we will also be able to make a very good point to allow VBID in HSA high deductible health plans. So the last is somewhat timely for our work in the American Journal of Managed Care is where does value-based insurance design fit in this very kind of high profile, controversial discussion about high cost, high value specialty drugs, such as those that treat rheumatoid arthritis, cancer, and now hyperlipidemia. We don't set the prices of these things. We understand that that is an area of great controversy and consternation. What we care about in the world of value-based insurance design, that patients get the right drug by the right provider in the right time in their disease at the right price. And while we strongly support many of our health plans that we work closely with to recommend strongly through financial and other incentives to get individuals to use first-line low-cost agents such as generic drugs, it's important for people to understand that in most common chronic diseases change over time and multiple therapies are often needed. So what we have put forth is an idea called reward the good soldier, which is something like step edit with copay relief, which means that if you have a disease that has a first-line low-cost therapy and you take it as you should, but the outcome that the patient and the clinician wants doesn't happen, your blood pressure is not lowered, your blood sugar is not lowered, your joints don't feel better in rheumatoid arthritis, that you actually get a copay reduction on what is now considered very high price, often out of reach, branded drugs to treat these conditions. So along the line of clinical nuance, we don't recommend first line of these high cost branded drugs for everyone. But at the same time, we want to make sure that when the clinical needs were to arise to need a high cost therapy, that the patient actually gets rewarded for doing the right thing and understanding that sometimes there's no option in the low cost drug category.